I think we're just about ready to start. If that's okay, I'll just hear from the team that we're ready to start. I think we are. Fantastic. So people will probably be joining us over the next minute or two. So we'll start slowly while everybody joins in. Firstly, welcome. My name is Christabel Saunders. I'm Professor of Surgery at the University of Melbourne, and I'm also President of All.Can International. And as is traditional here in Australia, I'd like to acknowledge that I'm joining you from the traditional lands of the custodians of this land, who are the Wurundjeri Woi Wurrung people of the Kulin Nation. And I'd like to pay my respects to elders past, present and emerging. And of course, welcome to any First Nations people who've joined today, this webinar. I'm very excited about the next hour. We're going to hear some really exciting things. So really what our agenda tonight is all about is to showcase this thing called the Efficiency Hub of All.Can. And I'll tell you a bit more about that in a second. But we really want to try and showcase some examples of good innovations in cancer care. We'd like to offer you a space to reflect on these and hopefully ask some questions and go away with some great ideas so you can replicate these wherever you're working. And I know that people are joining us from all over the globe, which is fantastic. So if you do have any questions, both during it and also we've got plenty of time for Q&A after the three presentations, please put your questions in the Q&A box and we can share them with our panelists and hopefully have a very lively discussion. So next, I'd like to introduce our three panelists for tonight. So firstly, we have you can all, sorry, before I start on that, I've just been told to remind you that you can also submit any questions in the chat box throughout the presentations. So going back to our panelists, our first panelist who you'll meet in a moment is Dr. Raquel Benitez. Raquel is from the Spanish National Cancer Center and also from Pancreatic Cancer Europe. And she'll be describing tonight something called Pancreos, the Pancreos project or Pancreos project. And this really demonstrates the power of leveraging data to improve pancreatic care and management, and to do that across many jurisdictions in Europe, which I think is a really exciting thing. Her background is in bioinformatics and biostatistics, and I know that Raquel is passionate about bridging the gap between innovation and real-world application in cancer care. The next person you'll be hearing from is Anthony Cunliffe from Macmillan Cancer Support. And Anthony is a lead medical advisor for Macmillan, but he's also a GP. And he joins us to really flesh out for us the Macmillan Decision Support Tool, which aims to support an earlier diagnosis of cancer for our patients. And Anthony brings both his clinical background, obviously as a GP, but also a lot of strategic knowledge and experience in really how to build more equitable cancer systems. And lastly, we'll be hearing from Aurelia Roman. Aurelia's dialing in from Romania, but is in fact from All.Can Canada. And really her mission is to make more complex information understandable and really let us allow research to inform systemic solutions to decisions in cancer. And Aurelia will provide an oversight of the Alberta Thoracic Oncology Program and how this has really improved lung cancer outcomes. So what is this thing, the Efficiency Hub? And maybe I'd just like to start by describing to you what we mean by efficiency at All.Can, because a lot of people are a bit confused about when we say efficiency. Is that just about saving money? Well, it's not. For us, efficiency is delivering the best possible health outcomes using available human, financial, infrastructural, and technological resources available, but very much with a focus on what matters to patients, as well as what matters to the system. And what we decided to do some years ago at All.Can is bring some really fabulous ideas together in something we call the Efficiency Hub. And I think it's a fairly unique resource that we hope will be widely used around the world. It's a first of its kind platform that really showcases things that people have proven have actually worked. So, you know, all of this that's on the Efficiency Hub has some evidence behind it. So you may be able to take and adapt some of these examples in your own settings. It gives us practical, high impact solutions for the problems that all of us face in cancer care. And it's designed really to be a generic resource, but one, as I say, that you can take away and adapt to your own uses. So if any of you do have any really good ideas for this efficiency hub, please do contact us either at AllCan or indeed at the Health Policy Partnership, and we'll have a look at your ideas and see if we can include them in the hub. Now, we better move directly on if we could. And first, I'd like to welcome once again Raquel Benitez from Spain, who's going to tell us a bit about advancing pancreatic cancer care and management using data. Welcome, Raquel.
Hi, can you hear me? Okay.
We can. I know, Raquel,
Yes,
you've got
perfect.
A bit of a sore voice, but you'll do your best tonight. Thank you.
Exactly. I am a bit under the weather today, so sorry about my voice, but I will do my best for you to follow the presentation. So thank you very much for your kind introduction. As Christoph mentioned, today I'm presenting this Pancreas initiative. I think that a number is missing there, but well, Pancreas is a European initiative that tries to connect all the registries on pancreatic cancer Europe that are across the continent. Our idea is to foster collaboration among the different registries, to pull data, and also to enhance the standardization of the protocols on collecting data across Europe. In this case, this project is focused on pancreatic cancer because, as you may know, pancreatitis is a very little disease that have a very poor outcome when it's diagnosed. And the main reason that this is happening is because this diagnosis is too late. So, and also there is not very much option to treatment, and depending on the physicians that treat you, the outcome varies a lot, or is the fact that more affects the outcome of the patient. So that's why in this case, collecting data across the continent is very critical to improve the outcome of the patients. It cannot be treated as an individual disease. So in this regard, if you can move to the next slide, please. The key objective of this ambitious project is first to impact on patients by providing a comprehensive view of how patients are managed in Europe in the different regions, not only by country, but also by specific regions inside the countries, because it varies a lot, specifically in big countries. Regarding the data accuracy, Pancreas would like to foster the accuracy on how the data is gathered and also reported. Then we would like to stimulate the cooperation between these registries for them to help each other to improve and also to provide some keys on how they are doing things differently in the different countries, also considering the constraints of the GDPR. And then we would like also to promote a better understanding of the disease by collecting all this information. And for sure, with all of these projects, we would like to finally contribute to the development of more effective prevention policies, diagnosis strategies, and also finally impacting in personalized treatments by all this collection of data. So you may wonder how we built this project. So if you can go to the next slide. Pancreas project is based on different type of registries. There are hospital-based involved, also population-based registries that are only focused on pancreatic cancer. All of these registries have been contacted by us. We did for a year a very specific research on the registries that may be interested in participate, and we contact all of them. And for those who show their interest, we start to move the project and how they see we can collect the data and how to make the effort. So this is a collaborative project led by Pancreatic Cancer Europe, but all the registries keep a role as a participant, not just a data provider. So at the beginning, when we decide how to collect this pancreatic cancer information, we have sadly limited resources. So we have to decide where to invest our efforts. So since we have this GDPR constriction in all Europe, which is the legislation that makes very difficult to collect individual data, it has to be very well anonymized, and then it's not useful anymore. We decide to request to the registries for summarized data, aggregated data. We are not collecting individual data. To this aim, we know that this is a bigger effort for the registries to participate and to provide the data, because they have to collect the data before to migrate to our platform. They cannot collect directly the individual information that they have. So in order to facilitate this, we decide to start by requesting the registries only about the numbers of the very specific disease, of pancreatic cancer, but also of the ones that, which is pancreatic ductal adenocarcinoma, which represent 95% of the cases, and also to adenocarcinoma not otherwise specified. But we also would like to identify in those registries how many cases are registered as other histologically confirmed pancreatic cancer type, but also those who were not confirmed, but they suspect that they was pancreatic cancer, because many times the patients arrive to the hospitals in very late stages of the disease where they do not have enough time for the pathologist to confirm the diagnosis. And once we collect all this information for the groups, we decide to, in this phase 1 of the project, to request the general information, which is sex, age, and so on, about the diagnostic procedures, tumor data, treatment data, and survival. We decide to request this information only for the pancreatic ductal adenocarcinoma cases, and also for the adenocarcinoma not otherwise specified that are on pancreatic cancer. And we define this code using the ICO codification, and we request to all of them the specific information only for those patients. Just for provide you an idea of the magnitude of this project, it collects at the moment the information of 64,000 patients in Europe. So we have a lot of powerful information that we need to handle in order to make a real impact at Europe level and also to the patients. So if you can go to the next slide. So far, we have 10 registries that already provide the data requested, and 28 that are on the process of the participation and signing the agreements and so on. So overall, with this, with the data that we have right now and the approach that we have made with the different registries, we for sure identify that there is a need to agree on the variables to be collected and to standardize the data collection processes among Europe regarding the pancreatic cancer disease. In this regard, the Pancreas Initiative is a very powerful tool to standardize the data collection processes, also to provide information on diagnosis, treatment, and survival, and to identify the heterogeneity of management and outcome among the different countries and also inside the different regions, because as you can see, in Spain, there are many races participating, also in Germany and in France, and also in Portugal, we have some races, so we can observe what is happening in the different regions. And also, Pancreas can point to issues for improvements. So right now, what we are working is in the assessment of the requirements and implications of including this network, Pancreas, on the European health, the European health networks of data. So space of data is what it means, the ATS. And we would like also to identify, with the data that we already have, areas for improvements to point out. So to sum up the impact of this project, we will say that this network of registries on pancreatic cancer is necessary and beneficial to society. And of course, it will make a real and fundamental change in what is known so far about this disease in the whole continent. This information is very valuable, for sure, for patients, which are our main beneficiaries, but it also benefits researchers, health providers, and also policymakers. So I hope by this end that I have convinced you of the importance of Pancreas, and I would like to invite you all, if you can go to the next slide, to contact us. My personal direction is Pancreas, and if you want to contact PCE, is the one that you have below. So please contact us if you would like to participate in the project, whether with a registry, or if you have any feedback, or you would like to use our platform as a question and answer, like I would like to know what is going on in Europe regarding pancreatic cancer in this regard, or if you would like to have feedback in building a similar platform in other type of disease across Europe or whatever, please contact us. And our most important part right now is to get to new registry for them to get involved and provide data. So if you know anyone that may be interested in to participate in the project, please let us know. And thank you so much for listening.
Thanks very much, Raquel. That's fascinating. I've got lots of questions, but what we're going to do is save them all until the end. So, wonderful. Thank you ever so much for that. We'll move on now to our next presentation, which is Anthony. Anthony, I introduced you earlier. I don't think you quite rung in yet, but thank you very much for attending. And you're going to tell us a little bit about the Macmillan Clinical Decision-Making Support tool that you have. So thank you very much.
No, thank you. Apologies for being a bit late. I'm on a temporary laptop, but hopefully I worked out the camera and everybody can see me now. Yes, I'm Dr. Anthony Cunliffe. I'm a GP, but I work with a UK-wide cancer charity called Macmillan Cancer Support. And we don't have an early diagnosis program now, but we used to have an early diagnosis program. And a lot of our work was focusing on primary care and how we could support primary care to diagnose, to think about cancer earlier, and then hopefully the subsequent impact will be earlier diagnoses of cancer. So do you want to go on to the next slide? So there was already some desktop cancer decision support tools that have been produced by two primary care academics, Dr. Willie Hamilton and Dr. Julia Hippersley Cox. And they'd done that based on, at the time, based on symptoms where people presented to primary care and what was the likely outcome either from single symptoms or combinations of symptoms that patient may have an undiagnosed underlying cancer, and then some advice on what a GP should do. And even though the desktop tools were great, we knew that reaching primary care is a real challenge. And for our GP, in England at least, I'm sure it's the same in many countries, we have very little time with the patient. And therefore, we felt that if we could integrate the algorithms that were behind the tools into the main primary care IT systems that we use across the UK, because there's mainly two across the UK. There is three, and so we work with all those three IT systems to work using the algorithms, but based on coded data in the IT systems, so that the risks of an underlying cancer could be flagged. And the idea is, so in England, we have NICE guidelines for the referrals of suspected cancer, which are based on a positive predictive value of that combination of symptoms of 3%. But what we wanted to do with this tool is to actually get GPs to think cancer earlier. So the PPV that the tool is based on is 2%. So if based on a single symptom or a combination of symptoms, that patient has a predicted underlying risk of an undiagnosed cancer or cancers, the IT tool would bring up a prompt to really trigger the GP to think about cancer and to consider what they might want to do, whether that might be doing some initial investigations or referring the patient on an urgent suspected cancer pathway. Now, this is based on coded data, and coding does vary across the UK as to the quality of coding in primary care. But unless the data is coded, whether that be symptoms or demographics, family history, etc., the integrated tool can't pick it up. So a big part of the work when we were introducing the tool into primary care was to really encourage the use of coding, not only of symptoms, but of all other data that might be relevant to an underlying cancer diagnosis. So the prompts are one of the functions of the tool. You can also, if it brings up a prompt, for example, of a potential underlying colorectal cancer, you can click on that and it brings up a whole list of symptoms that you can check that you've not missed coding some of them symptoms. And then if you code it, it'll recalculate the percentage risk. And the advice is anything over 2%, the GP should think about investigating for underlying cancer. There is also a risk stratification element to it. So you can do a search for all your patients that potentially have over the last 6 or 12 months have, based on coded data, got a risk of 2% or more of a specific cancer, and then review their notes to see if you feel that something might have been missed. There are, as I say, it's been introduced into all the IT systems across the UK. And I will just mention in a minute, as part of System 1 at the moment, it's part of a study called the ERICA study, which I'll just spend 30 seconds mentioning in a short time. But I should also say that there are other tools in the UK that have subsequently been built, and the names are there, that also perform a similar function. Some of them do more, some of them do similar functions. I should say this is a free tool to anybody in the UK who's using either EMIS, IMPS Vision or System 1. Could I have the next slide, please? I'm just going to mention the ERICA study. So this is to try, because what we don't have at the moment is any evidence that if GPs are using this tool on a population level, it will lead to earlier diagnosis of cancers across that population. So there's a large study happening at the moment, which is led by Willie Hamilton, who is one of the academics that produced one of the decision support tools called ERATS. And that study is currently going on, focusing on the 6 cancers that are mentioned there, and it should report in 2027, because one of the issues we've had is really getting GPs to engage and use the tool, and we're hoping if the evidence comes out that it does drive earlier diagnosis over a population, that we'll be able to encourage GPs to use it more. Not to go on to the next slide. So if you, the Macmillan Cancer Support website, if you go onto Macmillan Cancer Support and put in Cancer Decision Support Tool, it'll bring up all the information we have to support people to use the tool. There's some videos on there with frequently asked questions with both of the academics that created the 2 tools that the integrated systems are based on. And so I'd encourage people, if people are interested, go onto the Macmillan website and have a look at all the information we have there. And then next slide might just be my email address. Yeah, I didn't have too many slides because I was conscious we only had 5 minutes. But yeah, so essentially it's a free tool that's integrated into the primary care IT systems that, based on coded data, will bring up a percentage risk. Well, it'll only flag over 2%. And the idea is to then get GPs thinking about cancer, particularly when they might not have been thinking about cancer as a possible cause of the symptoms, and then investigate appropriately. And then there are multiple tools we have to then support people from that point onwards. I think that's me.
Thanks very much, Anthony. Really interesting program, and I'm sure there'll be some questions. I've certainly got some for you later as well, but thank you. But we'll move on to our next speaker, and I'd like to welcome Aurelia, who, as I say, is from the Alberta Thoracic Oncology Program and is going to tell us a little bit about how this works in Canada. Thanks, Aurelia. We just need to get the spotlight onto Aurelia. There she is.
Hope everything works well. So good morning, Cristobal. Good morning, everyone. It's a pleasure to be here, and thank you for the opportunity to present this work on behalf of All.Can Canada, which is a non-profit organization led by people with lived experience of cancer, working together to improve cancer diagnosis in Canada's healthcare system. At All.Can Canada, we are, as mentioned by Cristobal before, we are developing case studies based on best Canadian practices and programs in cancer diagnosis. Since 2011, the Alberta Thoracic Oncology Program is a leading Canadian example on how system redesign can accelerate lung cancer diagnosis. Led by Professor Dr. Alain Tremblay, the ATOP program offers rapid, state-of-the-art multidisciplinary assessment to people with suspected chest malignancies. Next slide, please. Just to give you an overview of the program, Alberta delivers publicly funded healthcare to about 5 million people spread across the vast geography comparable in size to France and Belgium combined. This creates a familiar challenge for many healthcare systems. So how do we provide fast and high quality cancer diagnosis when expertise is scarce? ATOP addresses this challenge through an automated lung cancer pathway within Alberta's healthcare system. There are two rapid access clinics located in Calgary and Edmonton. From there, ATOP centralizes referrals received from primary and secondary care professionals across the province. Patients are then seen by a multidisciplinary team of experts supported by nurse navigators and clerical staff. Together, they are managing about 3,000 cases per year. So in a nutshell, ATOP coordinates diagnosis, staging, and treatment planning, and ensures that patients have expedited access to all diagnostic modalities. Next slide. Thank you. The most important innovation in ATOP is the creation of an automated lung cancer pathway integrated within Alberta's referral ecosystem. So ATOP is using an automatic referral process, which is more efficient than the traditional referral system. Studies show that referral times dropped from roughly 3 weeks to under 5 days without compromising quality of care. What we can see here is a patient-centered design in practice made effective through the joint optimization of automation, human resources, and system-level coordination of multidisciplinary expertise. Next slide, please. So why this was needed? In Alberta, about half of lung cancer cases have been diagnosed at stage 4, when 5-year survival is extremely low, at only 13% of the cases. So these delays disproportionately affect people, communities in rural and remote areas where access to specialists and advanced diagnostics is limited or inexistent. Before ATOP, referrals depended heavily on clinicians, often family physicians interpreting CT scans, initiating referrals, and coordinating follow-up. This model produced predictable failures, miscommunication, duplication of tests, long waits, duplicated biopsies, and sometimes misdiagnostics. Patients waited sometimes beyond recommended timelines for an accurate diagnosis and treatment. So ATOP overall was designed to specifically fix these systemic failures. Next slide, please. In terms of efficiency metrics, ATOP met 5 of the 8 criteria proposed by AllCan International in 2022. Although it improves the patient experience, of course, there is always room for continuous improvement and refinement of what works. Alberta is now strengthening ATOP further, is expanding access to advanced diagnostics, is increasing teletriage for remote regions, and is aligning ATOP with lung cancer screening programs. Next slide, please. The key takeaway from this presentation is that delays in cancer diagnosis are mainly the result of fragmented systems. So synchronizing workflows between levels of care, primary, secondary, tertiary, is extremely important, as well as identifying the key decision points and clarifying responsibilities across domains. To close, I invite you to see this work not as a finished model, but as a transferable approach to system redesign in early cancer diagnosis. That will be all for now, and thank you for your attention and for your shared commitment to improve cancer care. On this slide, the contacts and resources will provide you more information and further details on the program design, governance, and outcomes. Thank you again for your attention.
Thanks very much, Aurelia. 3 fascinating presentations. I've certainly got a lot of specific questions, but somebody has come in. We might bring all of our panelists back in now, if we can. And somebody has asked a great question to kick us off. So we have plenty of time for chat. So please do think of some nice questions and pop them into the Q&A. But somebody has asked a really interesting question, I think, which will kick us off. And I'd like to ask each of the panelists this. So we'll go in order: Raquel, Anthony, and Aurelia. And you can all put your speakers and your cameras and microphones on if you like. Somebody has asked, what have been the key enabler for your program? And were there any specific levers that really made this successful? And I might start, Raquel, are you online? you are, maybe we could start by asking you that question. So what was the key enabler, and were there some specific things that allowed you to get this pan-European registry up and going?
Yeah, I think there are several aspects that may be key, but I think governance and trust on data sharing frameworks that we are provide were key. I mean, every time that we face an emergency that we like to collaborate with a project and so on, for us, the key point is always if they can trust the governance of the data or not. And also it's very important the clinical leadership, like who is impulsing, like enhancing the project, who is behind, who is the person who is leading this. And so I think those were the key aspects in the case of Pancreas to make it succeed.
Interesting that you don't mention funding and resources, that you mentioned trust and governance as more important. Can I just ask you,
maybe not as more important,
but
it's easier to find fundings and how to say that the stability. The stability for me is more difficult to build. It's easy at the beginning to get the funding, but then you have to maintain it based on this part, that people trust you. But it's not that what is more important than the other, it's just that they have to pick a key element. Okay, but for sure, funding is also very, very relevant. I agree with you.
And Anthony, can I ask you, what were the key enablers to getting the decision support tool, if you like, or the early diagnosis tool up and going? And was there anything specific about maybe the UK context that allowed it to work?
Well, I think there was the impetus before the enablers, I guess, and the impetus was a recognition for us in the UK that we were lagging behind a lot of other countries around the world when it came to earlier stage diagnosis, and a recognition that, again, in the UK, the majority of people that subsequently get diagnosed with cancer do start their journey in primary care. So we knew, there was a welcome focus that we needed to support primary care better to support them to get people diagnosed at an earlier stage. So that was probably the impetus. The enablers really were the fact that the academics had already been doing the research in this and had produced the desktop tools. We had an organization, so a charity in Macmillan Cancer Support, who was doing a lot of work with primary care and felt that the desktop tools were going to be really hard to kind of really get people to use, sustainably and consistently. And also it's hard to think about it when you're in a consultation, so that we knew that really for it to have an impact, it needed to be integrated into the tools that we're using every day. So that was one of the big enablers, but the other enabler was that the fact that the three main primary care IT systems in the UK, we had good relationships with them. So again, it goes to relationships, and they were willing to work with us to integrate the tools, and they were willing to do that for free because they felt it was a really good addition to their systems, and that it was something that the customers would want. So although it took a lot of time and a lot of resource in the form of time for both Macmillan and the IT systems, there was no actual cost to this at all. So we were able to make it available to anybody who wanted it, that were using those three primary care IT systems across the UK for no cost.
And so it does depend on you using that data system in your practice, that IT system in your practice. So it may not be transferable so easily to other systems in other countries, you think?
Well, it's the algorithms, so the blueprints that were the tools are based on are available. And, I'm not an IT person, but it really is just a matter of using the blueprint to code all the algorithms. I don't know how primary care IT systems work across the rest of the world, and because it is based on coded data, so it would have to be in a system where it could pick up those codes. Although I should say some of the newer systems are looking at potential to pick up free text as well, so that may change. And so it's definitely transferable from that point of view. I would say the evidence is based on people presenting to primary care in the UK. So it might be just as relevant to other countries that have a similar primary care gatekeeping system. The evidence might not quite map to areas that don't, although they are based on research and early diagnosis. So I don't think that is so much of an issue if it's just to make GPs think about cancer rather than using it as a mandate for referrals, etc.
Yeah. Great, thank you. And Aurelia, what about the thoracic initiative in Alberta? What were some of the key enablers, or what was the key enabler for that? And were there some things about your system, some levers that you could pull to make it work?
Absolutely. So ATOP shows that meaningful reduction in diagnostic timelines require redesign at the system level. So the joint optimization principle becomes the most important enabler. We have diagnostic technologies, nurse navigation, and multidisciplinary expertise aligning within this integrated pathway to provide value and reducing timelines in diagnosis. I hope this answers.
Okay. And did you have people affected by cancer involved in designing or implementing ATOP?
Yeah. Yes, it is my understanding that all pathways within Alberta's do have a participatory approach involving all sorts of shareholders and patients and representatives for important nonprofit organizations in their pathways. So the case studies is based on evaluation of the referral, automatic referral programs. There are no specific, there is not one specific mention about the involvement of patients, but I know that there are patients involved in the pathways.
Okay. And can I ask you, I'll stay on you, Aurelia, because I've got a few questions specifically for people. You know, one important thing that we think about in efficiency in cancer care is care close to home. Does ATOP include that? So it's not just pulling everybody in with lung cancer into the cancer centres. Is it enabling care close to home as well in such a large geography as Canada? Or is that not part of the system?
Well, there are the two main hubs in Calgary and Edmonton, and the automated referral program is trying to concentrate referrals, but there is also the telehealth and mobile units going into the regions, and the telehealth modalities pulling in people in the program. So it's both pulling in people through the telehealth models and having mobile diagnostic units sent into the regions where there are very, very little resources and expertise, and sometimes they are non-existent in some areas.
Yeah, and very big distances for people to travel. Yeah,
that is really an issue. There are long time travels that create a lot of additional issues as well for people, financial and logistical burdens. So geography is really the main access barriers.
Yeah, thank you. And Raquel, there's a specific question for you in the Q&A, and that's how some of the issues with pancreas can be overcome by the new regulation with the European Health Data Space. Maybe you could just briefly, I think some people know what the European Health Data Space is, but others won't. I don't know whether you've thought about that in your pan-European model.
Sure, just for the sake of time and to be brief, this GDPR legislation is what we all have to comply in order to collect data in Europe. So it is very restrictive, and you have to guarantee that the data is either anonymized or it is not anonymized. You need a specific consent for the owner of the data, in this case the patient, to get the data. And this is very difficult in pancreatic cancer cases, considering how illital it is. So this is a huge problem in diseases with very bad prognosis as pancreatic cancer, and also it requires a lot of paperwork. So the specific way, like in pancreas, overcome this was to gather, as mentioned during the presentation, summarized data. We are not requesting for individual data to each of the registries, but of the summarized data. So this requires a specific design, statistical design, on how we are asking these questions to the registries. It's not what was only the medium age, but the distribution of these ages, and we need to make the information comparable. So we also need to do how they did collect this information, if it was at the time of diagnosis, or so many variables were considered when designing this statistical analysis plan before requesting the information to the registries. And another counterbalance part of this situation is that we need to ask for the participants to do a major effort to provide the data, because they cannot directly to provide all the information that they already have to a server, but they had to carefully summarize the data and prepare it before providing us. We, of course, help them in preparing this data, and we collaborate directly with the data managers, and we provide them scripts and tools to make it faster. But even though this is super time consuming to overcome these constrictions, but it's possible. With imagination, a lot of time is possible.
And I mean, I'm quite excited by the idea of your registry. And you know, as things progress in pancreatic cancer, we are beginning to get treatments for it now. You know, it still is a dreadful disease. Are you thinking of trying to collect genomic data and other things like that as well into the future?
Yeah, absolutely. The problem with genomic data is again the same, that the GDPR and it is very difficult to anonymize genomic data. Maybe images is possible. We are building a different part of the project considering images, because it's much more easier to anonymize images, specifically radiological and pathological images. But for the rest of the genomics and proteomics and so on parts, it's much more difficult. So the way we're working right now is to requesting especially the hospital-based registries, whether they have this information or not. And if they have, we are trying to build somehow a hub where people can request data when needed, using the Pancreas platform to make faster and easier to know which information is available. But Pancreas for the moment is not planning to gather all together, because we don't have enough resources to build this platform and to handle all these individual informed concerns that maybe need to connect this information by Pancreas. So for the moment, it will be great, but we are just working in this part of building the hub to make the information more accessible.
Okay, thank you. Anthony, can I come back to you? I mean, if we've heard a bit from Raquel how they might want to think about expanding their project. If you could expand your project, one of the things that occurred to me is, you know, would patients have access to something like this? Would it be helpful for people to be able to look at their own risk and or not? Or are there other things that you're a GP, you see patients all the time coming with lots of red flag symptoms or otherwise? How do you think this should, you know, what are some of the things you'd like to see expanded in this?
Yeah, I think the point about patient-facing access is really interesting and important. It was, you know, a lively discussion at the time, but the decision at the time was that kind of the way the tool works and its multiple cancers, it might not be so. Well, you know, there was lots of debate, but it was decided not to at the time. However, I would say that some of the newer tools now, so there's one called See the Signs that's available in the UK and in the US, I believe, which is that's a commercial product, so you need to pay for it, and it does much more than just predict cancer probability. It's a referral management system, and it does various other things. And they have created something called See My Signs. So there is a patient-facing element. I think it's only focused on a couple of cancers at the moment, but they are looking at how they can develop that and then doing that with individual systems. But I think with the intention to make it patient-facing across all the functionality. From the CDS that we helped develop, there'd be no plans there unless our government, our health Department of Health, decided to take that over. At Macmillan, we don't have an early diagnosis program anymore, so we wouldn't have the resource to do that. And that would take a lot of work and a lot of funding as well. So it would need somebody to really own that and decide that, you know, that was something that was needed and that they felt the evidence was there that it could drive earlier diagnosis of cancer. So, you know, it's a possibility, but some of the similar tools are looking at that. Because actually, as far as the CDS is concerned, there's no expansion for us because it's already available for everyone. The biggest challenge for the CDS was not not integrating it and not getting it integrated for free. So there's no kind of sustainability issue there. It's getting GPs to use it, really getting GPs to buy into a new tool, which actually now isn't new. It's been available for a long time. But I don't know if it's the same in other countries, but we're a difficult group of professionals to reach GPs in England and across the UK. And the biggest challenge has been making people aware of it, getting people to be comfortable with its use. And there were lots of concerns around, because if you want it to, it will code that risk back into the system. And there was a lot of concerns from a litigation point of view, if you chose not to do something, whether there'd be an issue there. Our advice has always been that if it's pulling up a risk, it's based on coded data. So all those symptoms, you know, are already, or demographics are already coded within the system. So, you know, ideally we should have been thinking about cancer anyway. So that was one of the big challenges as well. But we may see, the Erica study that I mentioned, we may see things change if that does show that use of a tool like this across the population can drive earlier diagnosis of cancer. And the other tool I mentioned, See the Signs, as I say, it's a commercial tool, but they are starting to gather some evidence around specific tumours that it can drive earlier diagnosis over a population level.
And general practice does change. I mean, cardiovascular disease is a very good example, isn't it? Where GPs, well, at least in Australia and I believe in the UK, have wholeheartedly taken on cardiovascular risk factor tools, etc. So hopefully the same will happen with cancer.
Hopefully. And actually, one thing I should mention, Christabel, really is the other slight challenge with it is obviously research changes things. So, you know, there's a lot more research now on say, platelet level or red cell width and things, and how they can contribute to earlier cancer diagnosis. And so the tools the algorithms will need tweaking at some point for it to at least bring, I mean, it would still be relevant, but to bring in all the kind of newer research that's coming along.
When we all start having our circulating tumour DNA looked at,
absolutely.
That'll be a scary future. We're getting towards kind of beginning to think about wrapping up. So I just wanted to come back to the sustainability of these projects and how you financially, I mean, it comes down often to financial resources, doesn't it, to make things sustainable. So maybe I could start with you, Aurelia. You know, such an important project of making lung cancer diagnosis earlier and a smoother journey for patients and better care. Is this something that you've proven the health economic argument to government, and your government are happy to continue to fund this? Or what have been your struggles with making this financially sustainable?
It's a great question, and I think the best answers will be received from the managers of the program. I know that Alberta healthcare system is supporting ATOP. Without them, ATOP would not exist. So there are internal evaluations, there are more studies on this particular topic, and more information. I encourage the audience to contact the program directors and Alberta Health Services for this to answer this question.
Thank you. Makes sense, though. And Raquel, what about you? Final thoughts about how you're going to keep pancreas sustainable over the years, because it's clearly an important project.
Yeah, absolutely. This is another key point that we're always discussing among the internal team that is working highly active in pancreas. And what we think is that the way to this year will be critical for us, because we need for sure to convince or to get the data from the other 28 registries that did not provide it yet, to have more data for a proof of concept. And then we need to prove with examples that pancreas really works and it matters to patients and policymakers, researchers, as mentioned. And to do so, for us, is key also to introduce pancreas in the European health data space. If we get pancreas there, I think the sustainability will be much more easier, because you need to fulfill some requirements, demonstrating that you are continuously updating and getting data. And this data is easy to share with the rest of the partners or the stakeholders that may be interested. So if we get there, I think the sustainability is guaranteed. So that's why I mentioned that I think this year is key for pancreas.
And finally, Anthony, can I come back to you? I mean, early diagnosis of cancer is such an important thing. In fact, the recent World Cancer Leaders Forum, which was here in Melbourne a couple of months ago, we launched, along with the UICC, something called Mission Early to really consolidate that thought that diagnosing cancer makes the disease more treatable, it makes it cheaper to treat, and obviously much better outcomes for patients. And I think the key for that is often general practice. You know, most people in many of our jurisdictions will come through general practice, or of course some screening programs as well. Is there one thing you could say that you would like to, if you had a magic wand, what would you do, Anthony, to really ensure that general practice had all the tools they needed to make early diagnosis of cancer a reality?
If I was going to say one thing, and it's going off topic a little bit, it would be diagnostics probably. I agree, certainly in the system that we have in the UK, primary care, we're never going to drive significant earlier stage diagnosis or less late stage diagnosis unless, you know, without primary care. I mean, we are fundamental, we're the front door, we're diagnosticians. And so working with primary care is essential. And I'm really pleased to say that NHS England and the government are really, you know, committed to supporting primary care and are doing it in so many different ways now because that has been recognised. Access to diagnostics is very variable in the UK. And if we want GPs to feel fully empowered and confident in their role in their important role in diagnosing cancer earlier, we need to really broaden easier access to diagnostics and encourage GPs to use them more widely. Absolutely. So that would probably be my one big thing for us in the UK.
Great, thank you. Well, just to wrap up, we asked people at the beginning of this webinar to a few questions, and a couple of interesting facts have come through. 40% of you attending tonight had not heard of the Efficiency Hub before, so that's fantastic. Thanks for signing up to the session, and I hope that you've learned a lot, and I hope you'll go into the Efficiency Hub and see the dozens of other wonderful examples that we have in there. And the other thing that it really resonates with me is that the things that you flagged, which were least efficient in our cancer care systems, are care coordination across the pathway, delays in diagnosis, and long wait times for appointments and treatment. And that's really what patients say as well. You know, they want to have better joined up coordinated care. They want timeliness of diagnosis, but they also want patient-centered care. They want to make decisions for themselves and have a say in their decisions. And I think the three examples we heard tonight talk very strongly to how we can work on at least some of those important spokes of efficiency, of timeliness of care and better coordination of care. And it's great to hear at least we're beginning to think about using technology to do some of that. We didn't hear a lot about how we might use AI to make this even better, but I can already, you know, starting to think about how that could be used really in all three of our examples. And I think that's going to be a real revolution in the next year, whether that's, as you say, Anthony, you know, using large language models to have a look at notes and pulling things out, whether it's Aurelia, you know, being able to triage the patients and navigate them and give them information using AI rather than using nurse navigators, or Raquel, you know, using AI to interrogate that 64,000 patients, especially if you start collecting genomic data. That's going to be a hard task to be able to look at that and make sense out of it. So I think that's something, hopefully by the next time we have one of these, we'll maybe have some people beginning to integrate that as well into the fantastic information that's coming through. So we are almost at time. I don't think have any more questions. So I'd just like to thank our three panelists so much for really interesting presentations. I think they're things that we can all learn from. What I'd love the audience to do is say, oh, those are some good ideas. I'd like to go home and see whether we can use those where I come from. And you'll be able to look on the All.Can website. This whole presentation will be up there, and kindly all of our presenters put some email addresses and web pages at the end of their presentation. So please go and contact people and ask them and, you know, find out a little bit more. And you're more than welcome to contact any of the presenters or the email addresses that they've put in there to find out more about these examples. And as I say, finally, I'd just like to say to you, if you have some great examples, please do let us know. So on that note, thank you so much for joining. Thank you for the team at HPP for making this work, and good night.